Yeah, because like we presented for maybe 2 weeks, so we didn't know that we are. But yeah, I prepare like COVID-19 update. It's
Oh,
just
okay.
yeah,
Okay,
it's
that's great.
about seven. Yeah,
Yeah,
it's
I
not
was wondering
about.
who's gonna present that, so thank you.
Oh, sure, sure,
Thank you so much. Okay,
sure.
so we will wait probably just maybe a couple of minutes, or are we ready to start now?
Yeah, I can start. Yeah.
You can start. Okay.
Hello everyone,
Hello, Dr. Nader.
how are you?
Walaikum salam.
Hi, Dr. Nader. How are you doing?
Good, thank you. How is everyone
Thank you.
with the amount of the snow last week, last
Oh,
couple of days?
Yeah.
it it was a storm, like a storm.
Yeah.
Yes.
All right, so when you are ready, answer.
Okay. All right. I believe we are ready. So, hello everyone. Welcome to today's meeting. It's February 5th, and we will start our meeting by a COVID update from Sulafa. You can go ahead, Sulafa.
Okay, thank you. Can you see my screen?
Yes.
Okay. So hello everyone, and I will start with the COVID-19 update. I will start with monitor variant proportion. So for an overview, a variant is a virus with one or more mutation in its genome or the genetic code. A lineage or group of lineages, for example, is a collection of variants having similar genetic modification. So sometimes we saw this in many of viruses, in many of other microbes, but sometimes the genetic code itself changes over time, and this give a variant. Sometimes the variant is milder, but most of the time it will be stronger than the original virus. Due to similar qualities and characteristics that may initiate public health action, public health organization may label them as variant of concern, like as we heard of Omicron, they label it as variant of concern or a variant of interest. Some other mutation, they will label it as variant of interest or VOI. So as we know, all of us know, and everyone in this world know, COVID-19 is caused by SARS-CoV-2, a virus that is continually evolving and accumulating mutation in its genetic coding. New SARS-CoV-2 varieties are predicted to rise in the future. So many of public health professionals predict that many of new variants can emerge and can come uh, bring the COVID-19. Some version will appear and then vanish, while other will appear and spread, sometimes replacing prior forms. So maybe the last variant, and we have heard of Omicron, had been found in most states and territories as of December 2021, and remains the prevalent variant in the United States. So it's very like high in very contagious virus. One person can disseminate to more than sometimes I think 12, or have you heard another number? I didn't dig on it, but I've heard it's disseminated very widely. In the intermediate term, public health officials predict to continue to decline until the end of March. So the surge was very high, and I show you the trend from CDC. It was very high in the start of this year, but fortunately now it is decreasing. However, they believe this could be a window of opportunity to prepare for the likelihood of another COVID-19 wave caused by variation. So this is the trend. As we see, by the start of 2020, the trend was rising steadily. And by the end of the year, there was a surge. By the first months of 2021, it decreased again, and it fluctuates all the year, surge by late September and October, and again it's declining, and by the end of 2021 it rise to the maybe the highest trend since beginning, and now it started decreasing fortunately in the last few weeks. It will be beneficial to increase access to testing, particularly quiz tests. So public health do a great job in improving the testing for COVID-19. Now they have the quick test, and its sensitivity and specificity is also good compared to the previous one. So it is very beneficial if we know, like, we test more cases, we can implement public health measure. For example, if we know cases, we can isolate them. If we know cases and trace their contact, we can quarantine the contact. So implementation of public health measure can help a lot to decrease the dissemination of the disease and decrease the incidence. The federal and state government are also working together to improve the situation. Access to more effective N95 and KN95 masks, which can help to hold the spread of diseases and prepare for new variants. So this kind of mask is more to prevent the spread of the disease, especially for the Omicron variant. Okay, so all we hope of the ending of pandemic, not only for the physical health, but psychologically, for also worldwide economic, many of the causes we want this to be ended. But ending of the pandemic, or at the very least change to endemic status, will necessitate public trust in scientific advance. Vaccination is necessary from our side. So what we can do just to implement public health measure, like for example, vaccination, we should be vaccinated, not to reduce the vaccination, and many of the cause of refused vaccination, what is disseminated in the social media, the misinformation that disseminated about the role of vaccine and how it come out of the blue. Very, like, we know many of vaccine need years to develop, but we should tell the public that this vaccine going on for many than 20 years, because coronaviruses are many, and many have been like tested, and many of vaccination success through all phases of vaccination test. So from our side, we should like educate people and start from ourselves to be vaccinated, and to implement the other measure like social distancing and mask. This will help a lot. In survey taken at the end of 2020 and early 2021, 48% of Americans said they had a lot of faith in science. So this number is good, but we need more than this. We need more than this 48. And not only in United States, this should be like vaccination and public health measures should be done globally. COVID-19 must be eradicated globally. His public health measure must be undertaken globally, so the pandemic can end sooner. And this is my reference. Thank you so much.
ايوه
تمام. انت اوكي خلاص استنى بعد البتاع ما تمام المشكله
كنت طوالي يا بابا
ناخد طوالي.
Thank you so much, Sulafa.
انا ما مقدم الليل
For the presentation. And I believe someone has unmuted their.
Yes, I tried.
Yep. Yeah, I can hear.
Yeah, okay.
All right, thank you. Thank you so much, Sulafa, for this refreshing update.
Thank you. Thank you, Azza.
Yeah, I hope everybody is staying safe
Oh,
this
sure.
time of the season, this time of spreading again of the Omicron.
Yes. Hopefully everything will be better soon.
Thank you so much, Sulafa. It's great, really, and I appreciate your input. And
Thank
it's
you.
concise. Thank you. Appreciate
Thank
it.
you. Thank you, Dr. Nader.
Thank you. So anyone has any question, any update, any comment? I know that people are starting vaccinating their kids. Anyone did so with their kids so far?
Yes, I did, Sulafa. Azza, yeah.
Yeah, good.
Yeah, I started with the first dose for my son. He's 5 years old.
Okay. Is he
Yeah.
taking it well?
Yeah, no side effects. Yeah.
Perfect.
Yeah. However, I took the third dose of vaccine.
The booster
Oh.
dose. Okay.
Yeah, that one have a lot of complications. Yeah.
Yes. Thank you so much for sharing that good news, and hopefully like this will protect you and your family, and
Inshallah. Thank you, Sulafa.
thank you so much.
Thank you, Sama. Okay, and okay, are we ready to move on to our next part? Our next part will be a presentation about the endocrinology, and the presenter is Lina. If you are ready, you can start sharing your screen and start your presentation.
Can you see the screen, everyone?
Yes,
Okay. Can you hear me well?
good.
Today, our topic is going to be endocrinology in geriatric population. Just let me set this. Okay. First of all, we will start by talking about hemostatic regulation in geriatric population. The difference between younger population and geriatric is mainly that with time, the endocrinology system, as well as the other systems of the body, starts to get old as well. So we have many impaired endocrinology systems with aging. Loss of function is one aspect of endocrinology function, may result in compensatory changes in endocrine regulation and be associated with changes in catabolism that maintain hemostasis. In some instances, compensatory changes in hormone catabolism do not fully offset age-related impairment in endocrinology function. There's another aspect of the problem that faces geriatric population, it is the diagnosing of endocrinological disorders. Often present with non-specific, muted, or atypical symptoms and signs in older adults. Some patients have no complaints at all, and lab evaluation may be complicated with coexisting diseases. For many lab tests for older population, we don't have the normal range value for that test, so we face difficulties while performing lab tests. First, we will start by speaking about thyroid disorders. With normal aging, thyroxine T4 remains unchanged, while T3 remains also unchanged until extremity of ages when they decrease slightly. However, the distribution of thyrotropin concentration shifts towards higher level, contributing to the higher prevalence of biochemical hypothyroidism in older adults. So basically, the carrier thyrotropin increases in level, which leads to the hypothyroidism available in older population. Who went to test for TSH for all adults with recent decline in clinical, cognitive, or functional status for patients admitted for nursing homes. Hypothyroidism, as we know, symptoms are often atypical. Laboratory testing is necessary to detect most cases. Mild hypothyroidism and severe non-thyroidal illness can rapidly lead to severe hypothyroidism and myxedema, Subclinical hypothyroidism, which is elevated TSH with normal free T4 levels, occurs in up to 15% of the population older than 65 years. It's more common in women. What is the potential for confusion in diagnosing hypothyroidism? First, the non-thyroidal illnesses, which is two types, low T4 syndrome, which is low serum T4, free T4 usually normal without increasing TSH level in euthyroid patients with severe non-thyroidal illnesses. While T3, low T3 syndrome, the most common alteration in thyroid hormone levels in non-thyroidal illnesses occurring in even mild non-thyroidal disease. Secondary hypothyroidism, as we know, is due to normal or low TSH with low free T4, decreased reverse T3, or due to hypopituitarism. How do you manage subclinical hypothyroidism? Consider T4 replacement if TSH is more than 10 micro-international unit per liter. T4 supplementation in older population with mild elevation in TSH might lead to harm, so it is of limited benefit or even harmful. If not treated with T4, monitor TSH, free T4 every 6 months until stable, then yearly. In patients with severe hypothyroidism at presentation, you should exclude concomitant adrenal insufficiency and should be given stress doses of glucocorticosteroids to avoid precipitating an adrenal crisis. Hyperthyroidism in older adults in US, usually due to Graves' disease, triple the risk of developing atrial fibrillation within 10 years and present in 13 to 30 of older population with AF. Causes secondary osteoporosis and should be suspected in patients with low bone mineral density. Hepatic thyrotoxicosis, characterized by depression, inactivity, lethargy, and withdrawn behavior, often associated with anorexia, weight loss, constipation, muscle weakness, and or cardiac symptoms. The problem with diagnosing hyperthyroidism, most are asymptomatic, with low TSH are clinically euthyroid, with normal T4 and T3. And TH might be normal or on repeat testing, so you should repeat the testing 4 to 6 weeks later. T3 thyrotoxicosis, where there's elevated T3 level and normal T4 level, occurs in minority of hyperthyroid patients, but is more common with aging. High T4 syndrome occur in euthyroid patients with non-thyroidal illness or medication that cause elevated T4 level. Usually they have TSH normal. Clinical hyperthyroidism, which is low or undetectable serum TSH with normal T4 and T3, free T4 and T3, present in 2% of older adults without non-thyroid disease, associated with AF, especially if a TSH level is less than 0.1, as well as in people with thyroid function in high normal range, can accelerate bone mineral density loss. Low TSH is shown to be associated with cognitive impairment and dementia. It is unknown whether antithyroid therapy can prevent cognitive decline in these individuals. What's the treatment of hyperthyroidism? There's a lot of options. We start with radioactive iodine, treatment of choice in older adults with Graves' disease or toxic nodular thyroid disease. For toxic multinodular, higher or repeated doses are often necessary. Antithyroid drugs may be given before radioactive iodine to control the symptoms and avoid worsening of thyrotoxicosis due to release of thyroid hormone. After radioiodine therapy, measure the TSH level to monitor for eventual development of hyperthyroidism or persistent or recurrent hyperthyroidism. Nodular thyroid disease increase in incidence with aging. Thyroid nodules present in 90% of women more than 70 and 60% of men more than 80. Most of them are non-bulbable. Most of them are benign, but solitary nodules more often malignant in people more than 60. When to do an ultrasound for screening, after history of head and neck irradiation or multiple endocrine neoplasia type 2 or familial history of thyroid cancer. To diagnose unexplained cervical lymphadenopathy, selection of thyroid nodules for biopsy, guidance for fine needle aspiration on single or multiple thyroid nodules, identification of nodular characteristics suspicious for cancer, thyroid nodule discovered incidentally on CT, MRI, or PET scan. Thyroid nodules are rarely malignant. Non-functional or cold nodules require FNA to exclude malignancy. In general, more than 1 centimeter would require evaluation for malignancy. We move for parathyroid and calcium disorders. Circulating levels of parathyroid increase by 30% between the ages of 30 and 80. Serum calcium levels remain normal due to the increased parathyroid hormone. The balance between bone reabsorption and bone formation is altered in favor of reabsorption. This results in decreased bone mass and increased risk of osteoporosis with aging. Vitamin D deficiency is defined as circulating level less than 20 nanogram per milliliter. Very common, affects 26.5% of men, 33.6% of women of all races, more than 70 years of age. Natural sunlight is the major source of vitamin D. Even with adequate exposure to sunlight, vitamin D synthesis in the skin declines with aging. This is associated with muscle weakness, which increases the risk of falls, secondary hyperparathyroidism, which increases the bone turnover and bone loss. Population screening is not recommended usually, but we get the vitamin D levels in elder population when they are obese, malnourished or losing weight, have history of falls, non-traumatic fractures, osteoporosis, or they are using anti-epileptic drugs or corticosteroids to decrease bone mass in this. 2 vitamin D levels not useful except in late stage of chronic kidney disease. Optimal vitamin D levels for older population. The Geriatric Society workup on vitamin D supplementation for all older adults advocate minimum of a level of 30 for older adults. Less than 30 are associated with impaired balance and decreased muscle weakness and decreased bone mass density and increased fall rates. More than 75% of elder population in US have levels less than 30. How much to give? Usually the daily vitamin D intake should be about 800 international units in those more than 70 years of age. At least 1,000 units in older population along with calcium supplementation to reduce the risk of falls and fractures. High dose may cause hypercalciuria, hypercalcemia, impaired kidney function, and bone loss. Vitamin D deficient elder population should have 50,000 units per week for 8 to 12 weeks, followed by 1,000 to 1,050 for maintenance therapy. Hypercalcemia, usually primary caused by primary hyperparathyroidism or malignancy. More prevalent in women than men, usually asymptomatic. Elder population are more likely than younger to have neuropsychiatric symptoms with neuromuscular problems such as proximal muscle weakness and osteoporosis. Diagnosis is confirmed if parathyroid hormone is elevated or normal in presence of hypercalcemia. This is a different variety of levels of calcium phosphate, urinary calcium parathyroid hormone in relation to primary hyperthyroidism, hypercalcemia in pregnancy, and local osteolytic hypercalcemia. How to treat? Surgeries for patients with symptoms of primary hyperparathyroidism, but if they have no symptoms, but they have serum calcium more than 1 microgram per deciliter above normal, or creatinine clearance of less than 60, markedly decreased bone density, vertebral fracture, renal problems on imaging and stones, 40 urinary calcium more than 400, with increased stone risk by biochemical stone risk analysis, we should do surgery for them. Repletion of vitamin D deficiency may improve some manifestations of primary hyperparathyroidism, such as reduced bone mass density and risk fracture. Medical management, we can give them bisphosphonate, cinacalcet, or estrogen progesterone therapy. Hypercalcemia of malignancy is the most common cause of hypercalcemia in hospitalized patients. Presence of underlying cancer is usually evident. Either squamous cell from lung, head, or neck are common cause due to the release of parathyroid-related peptide. Other causes are breast cancer, lymphoma, myeloma. They are not related to parathyroid-related peptide. Treatment, volume replacement with IV saline, parenteral bisphosphonate treatment of underlying malignancy possible. Paget disease, localized area of increased bone remodeling, usually asymptomatic. Pain is the most common presenting symptom. Bisphosphonates are the treatment of choice. During the treatment, we should monitor for change in bone pain, joint function, neurological status, serum alkaline phosphatase, or bone-specific alkaline phosphatase. Anterior pituitary disorders. It's challenging to separate the effects of aging of pituitary hormone secretion from the effects of comorbid illnesses, medications, body composition, physical activity, and other confounding factors. Aging affects the pituitary hormone secretion, may only become evident in response to stimulatory inhibitory influences, but not in the basal state. The effect on hypothalamic pituitary axis, thyroid axis, unchanged thyroxine, decreased T3, unchanged TSH, suppression of TSH by T4 is increased. Organ hormone levels affect effect of aging on organ hormonal level. Cortisol is unchanged, ACTH unchanged, but there is decrease in diurnal rhythm of cortisol and ACTH. ACTH stimulation of cortisol is unchanged. The feedback is unchanged. Stimulation of ACTH and cortisol by insulin induced hypoglycemia is unchanged, and recovery of ACTH and cortisol after stress is decreased. The effect on growth hormone, insulin-like growth factor is decreased, as well as growth factor secretion during sleep, fasting, and exercise. Amplitude of the pulsatile secretion of growth hormone is well decreased. There is unchanged in the pulsatile secretion frequency and response to insulin-induced hypoglycemia. Growth hormone response to growth hormone-releasing hormone is decreased. Testosterone, or hypothalamic pituitary testicular axis, total testosterone is decreased, free and bioavailable testosterone is decreased, sex hormone binding globulin is increased, LH is unchanged to increased, FSH is unchanged to increased, pulsatile LH frequency is decreased, LH response to gonadotropin releasing hormone is unchanged. Prolactin, there's an increase in the level of prolactin, nocturnal secretion of prolactin, and the amplitude of the pulsatile prolactin secretion. Final pituitary adenomas increase in incidence with change with age, but remain asymptomatic. Most of them are non-functioning. We have to perform thorough and full clinical evaluation, measurements of the pituitary dimensions and end hormone levels to exclude hypopituitarism and hormones hypersecretion, and visual field examination. Pituitary microadenomas may be managed expectedly. Macroadenomas other than prolactinomas should be referred for transsphenoidal surgery if there is a visual field abnormalities, hypersecretion of TSH, ACTH, and growth hormone, or other neurological symptoms. Hypopituitarism, on the other hand, a third to half of the elder population with pituitary tumors develop hypopituitarism, all caused by traumatic brain injury, infections, metastatic cancer, pre-radiation, surgery for pituitary tumors, and vascular disorders. Manifestation of panhypothyroidism include fatigue, hypogonadism, loss of libido, hypotension, weight loss, hypoglycemia, and hyponatremia. When diagnosis suspected, measure the pituitary dimensions and target organ hormone levels, including dynamic testing of or HPA axis with ACTH stimulating test. Even after minor falls or trauma and head injury, acute hypopituitarism may occur in elder population. Potentially life-threatening glucocorticoids insufficiency may develop in acute phase, which is the first 7 to 10 days. Obtain serial morning cortisol measurements, especially when hypotension, hypoglycemia, and hyponatremia are present. After the acute phase, some hormonal deficiencies that were manifested early may resolve, and other may develop. Empty cell syndrome observed in 19% of elder population. Pituitary height and volume tend to diminish with aging in healthy adults. Increasingly being detected in neuroimaging for other indications has increased. Unknown whether it's functionally significant or not. Conservative management is appropriate in these cases with visual field testing and pituitary and target organ hormones measurement to detect abnormalities. Adrenal cortex. Regarding the adrenal cortex, there is decreased cortisol secretion balanced by decreased clearance. Cortisol and ACTH response are unimpaired. Acute cortisol response may be higher or even prolonged. Unless emergent, adrenal function test should be delayed more than 48 hours after major stresses such as trauma and surgery end. We should do endocrinology consultation if ACTH stimulation test is normal, but adrenal insufficiency is suspected. Hyper-Adrenocorticism causes are chronic glucocorticoids therapy. This is the most common cause in elder population. Other less important or less common causes are autoimmune mediated adrenal failure, TB, adrenal mets, adrenal hemorrhage in patients with anticoagulating drugs, or prolonged use of mistrojol acetate. Possible symptoms: anorexia, nausea, weight loss, abdominal pain, weakness, hypotension, impaired functional status, hyponatremia, and hyperkalemia. Once suspected, ACTH stimulation test should be done. Regarding hyper-adrenocorticism, exogenous glucocorticoids are the most common cause in elder population. Usually they present with psychiatric and cognitive symptoms, osteoporosis, myopathy, and glucose intolerance. For patients beginning long-term glucocorticoid therapy, baseline and follow-up bone densitometry measurements are indicated. Adrenal neoplasm, usually there are incidentalomas present in more than 10% of elder population. Most of them are benign, though few chromocytoma and adrenal cortical carcinomas are also found. Goals of the assessment is to determine whether it's functional or not, and to determine whether it's benign or not. Via supplementation that are converted to more active androgens and estrogens in adrenal gland and peripheral tissue. Oral supplementation is available only as a dietary supplement in the United States. The potency and the purity of the preparation is unreliable, and the long-term safety of them has not been established. Testosterone with age, the total level is repeatedly and unequivocally well below normal. Severe symptoms of androgen symptoms and no potentially reversible contributing comorbidities, all of these lead to the diagnosis of low or hypogonadism in elder population. More common, they usually present with low, normal, or mildly decreased levels, thyroxine levels, testosterone levels, sorry, and non-specific symptoms such as decreased libido, potency, energy, mood, weakness, decreased muscle mass, osteopenia, metabolic syndrome, and memory loss. How to evaluate them? If there is a sign and symptoms of androgen insufficiency, obtain morning serum-free or bioavailable testosterone level. If it's low, repeat the testosterone level and obtain LH and FSH level. Baseline bone densitometry if there is a high fracture risk. If gonadotropins are low or low normal, review the medication that the patient is receiving that can suppress gonadotropins and obtain prolactin level. If prolactin levels is high, refer to the endocrinologist and further studies should be warranted. The advantages of testosterone level is increasing body mass, decreasing fat mass, increasing bone mineral density at the lumbar spine, increasing the grip and leg strength in some studies, as well as improving sexual activity. There's a variable effect on mood, no improvement in the cognitive function, inconsistent effect on quality of life, decrease or small decrease in total LDH and LDL, HDL, and cholesterol, may increase the risk of cardiovascular events in elder men with extensive CVDs and immobility. Regarding the prostate, it may increase the incidence of prostate-relevant related effects, and PSA increased slightly. The supplementation should be considered only after optimizing potentially reversible functional causes of hypogonadism, such as stopping medication that may cause clinical manifestations of hypogonadism. Also, after discussing the risk and benefits with the patient, they should receive close monitor for efficacy and adverse effects. We have two cases. I know this is a very long presentation, but the topic is really huge. So first case, we have a 72-year-old man came for follow-up after recent hospitalization for bacterial pneumonia. At the hospital, CT of the chest disclosed an incidental thyroid nodule. He has a history of COPD, hypertension, and CAD. He has had no recent weight loss, temperature intolerance, change in appetite, hair loss, or change in mood or energy. The nodule is palpated on examination of the head and neck. Thyrotropin level is 2.5. Which of the following is the most appropriate next diagnostic test? I should through the chat. So the correct answer is ultrasound for the head and neck. Second case is 76-year-old woman came to the office for a routine visit. She says she is more fatigued in the evening than she has been in the past. She walks about 2 to 3 miles per day, watches her 3-year-old granddaughter once a week, and gardens. She has a garden. There are no changes in her sleep, weight, and appetite, no night sweats, heat or cold intolerance, hair loss, joint swelling, falls, confusion, or remorse. History, she has hypertension, osteopenia, and glaucoma. Medications, she receives hydrochlorothiazide, calcium carbonate, cholecalciferol, omeprazole, timolol. On examination, her temperature is 36.8, blood pressure is 134/85, heart rate is 72, respiratory rate 12, and BMI is 26. CBC is normal, thyrotropin is 5.06, free T4 is 1.2, vitamin D is 32.8, and vitamin B12 is 400. Which of the following is the most appropriate next step for managing this patient fatigue? Start levothyroxine, 0.25 microgram per deciliter. Recheck thyrotropin. Check level of methylmalonic acid. Increase cholecalciferol range to 1,000. So Sulafa is right. Please check thyrotropin level. And this is the end of my presentation.
Thank you so much, Lina. Thank you for your presentation. This has been a very excellent, concise presentation for a big topic. And anyone has a comment or a question for Lina?
Thank you so much, Lena. This is great also. And as I mentioned, it's concise. It's a big topic, and you went over the main key points. And this is what you're going to see when you start your residency. So keep in mind when you see all the others. Thank you so much.
You're welcome. Thank you.
Thank you. All right. If no questions or comment, we can move on to our next part or next section of the meeting. All right. So our next section is about how to prepare or how to do a PowerPoint poster presentation. Okay. So anybody has ever done a PowerPoint poster presentation before? Anyone? All right, so I will start sharing my screen. I'll do a brief, I'll do like step-by-step example of.
Hello, Azza.
Yes. Hi. Hello, Mohammed.
Yeah, I think yesterday, Hassan, the leader of the green group, asked me to do the.
Oh, okay. Yeah, he didn't confirm with me, so I thought that
No, it's
yeah,
good that
it's
you
okay. I
prepare.
can do it if you are not ready.
Yeah, we can do it together. So I can do my part and you can
Okay.
add your. Yeah, your.
All right, you can start. Go ahead, and I
Uh,
can jump at any time.
but I don't know how to share screen.
Do you see the green bottom then down?
Yep. Yeah.
You got it?
Yeah.
Okay.
Yeah. So do you see my screen now?
Yes.
All right.
All right.
Hello, everyone. So it's loading now. So, all right. Today I'm going to present how to create a poster presentation in PowerPoint. We have like 10 simple steps how to make a poster presentation in PowerPoint. So number one, to collect poster materials and to launch software, set dimensions and poster size. Number four, to add text. And five, add images, adjust colors and design elements, move elements on the poster canvas, use the pretest template, which is optional, and export for printing. And number 10 is printing and distribute. We're going to go on these 10 steps in a little bit more details. So for number one, to collect the poster materials before starting on a PowerPoint poster design, sit down and figure out what is going on with your poster. Then write out a plan for the design and collect all materials in a folder on your desktop or a text, charts or data, photos or other graphics. Okay. Step two is to launch the software. So you just navigate to PowerPoint on your computer and open the software. Start with a blank template. It doesn't matter which version of PowerPoint you use to create a poster design. Here I'm using 365 version, but the steps and locations of menu are similar on all modern versions of the software. So like an example here in mind. Yeah, it's like having new slides. So you have a different shapes and designs here. You can use the one that would fit with your poster presentation. Sorry for that, my internet is a little bit slow. Again, the same, this is a different version of Microsoft PowerPoint. You see here, you click the new, give you new slides. Most likely you can use the blank presentation and you create your own style or shape of the slides. Number three is set dimensions and poster size. Just pick up a size for your poster design and design the PowerPoint poster at the maximum size it will be printed. And just keep in mind that the large size of the maximum slide size in the PowerPoint is 52 inches wide and tall. And then set the dimensions in the design menu, navigate to the slide size, and click the drop down and select the page setup as I did just a few seconds ago. And then enter your page size. Note that most posters use portrait orientation. We have landscape and portrait orientation, but most of the posters use the portrait orientation to write the elements and the divisions of the poster. The portrait is tall and thin, taller and wider. And you have to select the design, click on the design here, and then you choose the size, the width, and the height of your slides from here. And then you can add a text once you have the layout set. Do all text elements to the poster design. Remember to keep the goal of the design in mind and keep text limited to only what's necessary, such as event name, time, date, and location. Don't worry about placement yet, but you can think about the fonts you want to use and how large text elements should be as you create a hierarchy for how people should follow the text on the poster. When it comes to the type size, start with a headline of 75 to 100 points and a body size of 24 to 48 points, and adjust the rest of your type hierarchy accordingly. And as we know, all of us, we have been a part of a poster presentation, and we see that started with the headings with a large size font size, and then the font going down, decreasing in size inside the elements. You can see that in the end of this presentation with some example of the posters. Then we can add an images to our presentation, as we know that posters as it's like some literature, some charts, and some images. Bringing images and other design elements you want to use into the poster design, drag and drop each image from your folder into the poster design. This is also the time to import or create any charts you might want to use. So in the PowerPoint, we have an option just to bring, like when you click here on insert, you have the options of pictures here. You can just drag down this arrow here, and either you can select from a picture or a chart from your computer or your device, or from your own OneDrive or Google Drive, or even you can just go make a copy and bring it and paste it on the slide. Okay. The goal is to get everything you might include visually in the poster design on the screen. When it comes to making a poster design in the PowerPoint, it's a lot easier to put it all together if all the elements are on the canvas, so you can see what you have to work with. Make sure that all of your images are large enough to print as well. Images pulled from websites are often not large enough to use for printed elements and will look blurry or pixelated. So you can make a download of a picture from the website into your device, and then you can just make copy, or just, as I mentioned earlier, you can click on the picture and bring it. So some pictures that when you copy and just paste them on the slides, they are appear blurry or sometimes even very small that you can't make them large enough to fill in the page. So you see here in the home page in some PowerPoint versions, click on the home here, and then you will, one of the icons here, you see the picture format, just click on that, and then you will get the options either to insert or to add a text. Yeah, you have here the picture. Drag down as we mentioned, and just upload from your computer, download from upload from your computer, or just copy and paste. Step number 6 is to adjust colors and design elements. So once you have all design elements available to work with, make adjustments so that every element in the right location. You can adjust font color and size, positioning, and even colors on text boxes to ensure that every element is easy to see and understand. Remember that when it comes to poster design, you want elements to be large enough to read at a distance. Avoid tiny text or design elements. Step number 7 is move elements on the poster canvas. So play with where elements are located on the poster canvas and move them around so that the poster design is easy to read and understand. You can move from right to left to the middle and so on. Most people will read the poster from top to bottom. Stack your information in such a way that makes this type of reading easy. Commonly, the headline or biggest text will be at the top and smaller elements will be in the lower part of the design. Number 8, use Pretest template, which is an optional. So you can create your own template and use it for your poster presentation, or even you can use a preset template. If you are lacking design elements for your poster, consider using one of the predefined templates in the PowerPoint to add some visual flair. Templates are available in the design menu, include high color options that will fit the canvas size you have selected. Number 9, export for printing. Once the PowerPoint poster design is ready, export the file for the printing. The most common and general accepted format is a PDF. Yeah, as we all did for our poster presentations, we just make them in a PDF format. After saving your file, navigate to the Acrobat menu or File menu in the altered versions. Then select or create a PDF. The software will do the rest. So in my version, just click, which is the old one, click on the file, and you find download as a PDF. Okay. This is another version in which you can see the Acrobat. It's already there, and just click on the Acrobat and we'll get the options of downloading as a PDF too. So yeah, it's here, it's Acrobat, and you will get the options for the menu and how to download your document as a PDF. So the last step in creating a poster in a PowerPoint is print and distribute. So you put your, you can put your PDF on a drive to take it to the printer or email it as we all know, which is one of the easiest steps in creating a poster. And once the design is printed, you can distribute your poster made in PowerPoint. This is a template how to create or how the shape of the posters look like in PowerPoint. You see here the size of the font, large, and then getting smaller, and then you inserted the pictures, the table, and a chart. So in the conclusion, while PowerPoint might not be the ideal solution for creating a poster design for everyone, it's a viable solution if that's the only software you have available. One of the biggest constraints can be that the PowerPoint files do have a limited size. So make sure that is appropriate for your design. And one benefit of creating a poster in PowerPoint is that you can import elements or images that you had made in other software in formats such as JPEG or PNG. Thank you. Any questions or comments?
Thank you so much. Thank you, Mohammed, for the nice presentation. And as you said, before you start creating the poster, just look at the guidelines for the specific conference that you're presenting your poster at. They will say what font size, what size of the poster needed to be, and how many tables to be included and how many charts to be included. And there is, some of them say that you have an option to create a QR code for the poster so everyone can scan it and get the whole article or the whole manuscript that you created your poster from. So thank you so much, Mohammed. Anyone has a question, addition?
I just wanted to share one of
Yes.
the poster presentation that we did this last year, which is presented by Dr. Sarah. You see it?
Yes.
Yes.
So thank you so much, Dr. Mohammed. Can you put it back? I just want to comment on some of the things. But thank you so much, Dr. Mohammed. This is excellent presentation as well. And you divided into the steps that anyone can follow. And this is really helpful. Hopefully, it will help some of you down the road. And I want to share with you good news that Dr. Salma and our team submitted an abstract, and that was accepted. So we will go over some of the steps, maybe to apply some of the concepts that Dr. Mohammed just shared. In this poster, I want just to add some of the points. So as you mentioned, Dr. Mohammed, you want the font to be large and can be read from a distance, the title, the authors, and the institution or institutions involved. And then you go over the design. In this format, there are 3 columns. You can put it in 2 columns or it depends on what you want to present, the graphs and the chart or the pictures. You want to also acknowledge and put your reference on at the end or at the bottom. So on the right upper corner, you want to put, if you want to add the QR code or the icon for the institution, for instance, you can put it also as well. So there are other components that you want to add to the poster. The poster can be done for a visual presentation. So most of these posters in the past 1 year or so, we present them virtually, so it's an online, and people can look at them and can download them and can focus or view certain areas so they can read it more obviously. So it's going to be maximized for the viewer. Thank you, Muhammad. I'm going to share with you my screen now. And I'm going to... So the instructions, as you mentioned, comes from the group of the conference organizer in Dr. Selma's and her team case. They just sent her these instructions for poster, the size, as you mentioned. Most of the size for an actual in-person presentation, you need to print it as a big poster. So it's need to be 36 inches tall, and then the width varies. In this case, it's 42 inches. Most of the printers, they have the 36 wide option. Some might be larger, but most available, like in universities or at FedEx, you can find them. You can find them the width 36 inches, at least here in the US. They can provide you a wall where you can put your poster on that on site, as here mentioned. It's a tripod. Then you can also follow the other characteristic of the elements as they here mentioned, character-wise, space-wise, and so forth. The layout of the poster, as mentioned here, you need to include your subtitle or like the introduction, the method, result, conclusion, and as mentioned, the references if there is any acknowledgement. PowerPoint is good at helping you with that, but there are other templates or other software you can use. Some of them you need to buy, some you need to use like free. For instance, you can use Google Slides and share with you here. So for instance, this one, I'm just gonna talk a little bit about the in-person. The in-person poster. So the size will be given to you and the layout and the instructions. So when you print it, you can go for, like the university here at MSU, they have a big printer, or you can go to FedEx, they can also print the poster for you. You need to make sure it's printed the right size, the wording. Sometimes the printer might have problems, so you want to check it before you take it from the printer office or the library, for instance. Then when you hang it out, you can be present at the poster site. People will come over and you can be alone presenting your poster, or you can be with a group of 2 or more presenters. Most of the time they will come to assess your poster a group of judge, maybe more, 2 or more. So you present the poster, they will ask you questions, and then you may give additional information. Sometimes you may not have the space to put all the details of your research work. So at some time you want to present or print a small sheet of paper where you can put additional information. This is the goal. This is called the handout. So you can hand it to people who come and ask you a question, or they want more information, for instance. Thank you.
Thank you so much, Dr. Nader. Thank you, thank you, thank you, Mohammed. Thank you again. Anyone has a question for Mohammed? And congratulations, Dr. Selma and your team for being accepted. That's a great news. All right, so we'll move on to the updates. As we heard from Dr. Nader, the good news and the update. Anyone else has an update for their project? Or project updates?
Hello, good afternoon, everyone. Good evening. This is
Hello, good evening, Lubaba.
Yeah, thank you for the great presentations. We're very informative. We really appreciate these points. So we'll make sure to add all of these to our next posters, hopefully. We submitted last week for American Alzheimer International Conference, the Dementia Paper, again, abstract. Hopefully we can hear good news from them alongside with a couple abstracts as well. Despite that, I found in the website that if the material has been presented before in a conference, it might not be accepted, but we reached out at the beginning and they advised us to change the content, or maybe not to be the same words that we submitted the first time. But we did, and thank you for the team, for the dementia team, and let's hope for the best. Thank you.
Thank you so much, Lubaba, for sharing, and hopefully good luck that you will be accepted too this time.
Thank you.
All right, anyone else wants to share any updates? All right, any other updates regarding the season? Are you ranking your programs? Anyone has a problem ranking and submitting?
I don't have problem for ranking. I don't have that long list.
Yeah,
I think it's advisable to send a letter of intent at this time, just to remind the programs that you are interested to train with them, and that you are going to rank them in the top of your list. Just an advisable thing to do. And good luck for everyone.
yes, good luck for everyone. And I think you can mention that you are ranking them high, right? Or ranking them first or something like that.
I'm not sure about that. Yeah, some people advise that you can mention that you're ranking them at the top, but not number one. I'm not sure, 100% sure. So it's kind of personal preference at this point. There is talk about that, but I'm not sure about what is the right way. Good luck.
Thank you, Lubaba, and good luck for everyone. Hopefully we'll hear the good news this year and everyone will match. All right, anyone has a question?
So also, as Lubaba mentioned, we submitted some other abstract to Alzheimer Association. 2 more, one for music, and there's another one for another topic. Anyways, we have 3 posters or abstracts submitted to Alzheimer's. So we can wait and see if they accept any of these. So good work, everyone. Excellent. Good job. Good luck.
Perfect. Thank you, Dr. Nader. All right, so are we ready to discuss what is for the next meeting? But anyone has any suggestion, anything that we need to discuss in the following meetings? Anyone who needs anything specifically to be covered? All right, so next meeting.
Again, I put names here. I think just the topics, we can change these or we can add or remove names. So,
yeah.
Osama with us? If Dr. Osama,
yes, I'm here.
Are you willing to lead the meeting and present? Okay.
Yes, I can lead the meeting and I can present the first topic, and I will reach out the blue team for the rest of the topics.
Excellent. Any specific area you want us to focus on, other fellows, any suggestions? So we're gonna go over musculoskeletal pain maybe, and some organizational skills if you want to share some points as far as what we can do for the matching, and maybe we can also touch upon the SOP program. It's gonna be next and the update. If possible, maybe the team who is going to present the poster at AMDA, one of the poster about the activity in nursing home, can they present that to us? I think we're gonna do virtual presentation for that. So the fellows here can give you some feedback, or if you are not ready, maybe the other team. I think it's pain management. So I just put it here as presentation for poster that will be presented at, and I selected the activity in nursing home for the team.
Yes, they can do like a rehearsal presentation and to get their feedback during the meeting. All right. Right, Lubaba agrees. Right, perfect.
And I'd like to thank you all for completing the review or the feedback and reflection about the fellowship, about your role and what we can improve and how we can improve. So thank you so much for the feedback. I want also to encourage those who did not do the feedback. I sent an email with a link. It's like a Google form. Yeah. If you can just do that in a couple, like in the coming days, that would be great. The rate so far out of the 40-something people in the fellowship, we got 26 response, so about roughly 50%. So there a group of you did not do that. I encourage you to do it. It's going to be very beneficial to the fellowship and the future, and hopefully we can make some adjustments so that you can focus on the areas that you want to improve on. By the time hopefully you get into residency, you'll have the tool and the skill to carry on with your research activity. Thank you, everyone.
Thank you, Dr. Nader. And the survey is available also in the WhatsApp group. So if anyone haven't seen it in their emails, you can reach to the WhatsApp group and easily to complete the survey from there.
And for the coming meetings, if you go to the app, you can just log into the app and see upcoming Zoom meetings, and you can select which meeting you want to present. For instance, the week after, if you want to put your name, you can put your name somewhere here, the topic or the area of interest that you want to share. And it's just an opportunity for you guys to learn, practice presentation, share with your fellows. And this will be written in your CV that you participate in these activities by presenting here or leading a Zoom meeting or some sort of that. Thank you.
Right. Thank you, Dr. Nader. And anyone else wants to add anything? Now we created a group also. Somebody created a group for the group leaders. I think that is a good idea, and it helped to organize the meetings. And some of the groups, I think maybe in the future we can like rearrange the groups, because some of the groups has more members than others, because we don't want the burden to fall on so a lot of it. Yeah.
And I think that maybe I have a suggestion.
Sure.
Okay.
Fellow. So before, like every Saturday, if it's continued on Saturdays, if I like have few quiz or some questions for the fellows to go solve and read about, and make them more motivated to be participating actively in the Saturday's presentation.
Yes, that's a great idea. Like more interactive, you mean?
Yes. Yeah.
Yeah, that will be great. Yeah. Thank you.
Yeah, that's a great suggestion.
That's a great idea.
Good. So if no other comments or any suggestions, any feedback, I think we come to the conclusion of this meeting. I'd like to thank you, everyone. Thank you, Waza, for leading the Zoom meeting, and thank you all the presenters and the audience. Thanks for your participation, and I wish you all the best.
Thank you. Thank you, Dr. Nader. Thank you for the presenters today, Lubaba, Lina, Muhammad. Thank you for everyone.
Next week. Assalamualaikum. Bye.
Thank you so much, Dr. Nader. Thank you.
Thank you so much. Thank you very much, everyone.
Bye-bye.
Thank you. Thank you, everybody. Assalamu alaikum.
Wa alaikum salam.
Thank you. Thank you, everyone.